You know that feeling?
Yeah.
It's Saturday night. You've just had this massive meal, maybe a few too many slices of pepperoni pizza or a steak that was just a little too rich.
Oh, yeah.
You sit back, you're happy for maybe 5 minutes, then it starts. That slow rising burn right in the center of your chest.
The universal signal that you have,
Yeah.
definitely overindulged.
Exactly.
Yeah.
We all know that sensation. We pop an antacid, we complain about getting old, and then we just move on.
Right.
But while we're dealing with that sort of surface-level misery, there is a really complex, high-stakes drama playing out inside our anatomy. And I don't just mean digestion. I mean on a structural, cellular level.
It's incredible. It really is a mechanical marvel that we take for granted until it breaks. When you actually look at the plumbing, it's fascinating how precise it all needs to be.
So today, we're going to stop guessing what's happening down there. We're going to take a look. We're basing this deep dive on a fascinating video lecture from Dr. G.S. Raju's YouTube series. He's an expert endoscopist, and this video, it's specifically on the pathology of esophagus and erosive esophagitis. It's basically a guide to reading the human body like a map.
It is. And what's so effective about Dr. Raju's approach is he just strips away all the mystery. He doesn't just show us a sick patient. He shows us the detective work. He shows us how a doctor navigates the geography of the gut, measures the damage, and then assigns a grade to all that chaos caused by acid reflux.
And that is our mission today.
Right.
We are going to simulate that journey. We're going to visualize what a perfectly healthy esophagus looks like, which, spoiler alert, is a lot more specific than just a pink tube.
Yeah.
And then we're going to see what happens when the anatomy physically slides out of place.
The hernias, yeah, that's where the geometry starts to get really interesting.
Like the hernias. And then finally, we're going to decode the Los Angeles classification system, which sounds like, I don't know, a noir detective thriller or something.
It does.
But it's actually the global standard for grading how badly your insides are being, well, eaten away.
It's a grim scale, for sure, but a necessary one. It really dictates everything about how a patient is going to be treated.
Now, full disclosure here, I'm usually the person who, covers their eyes during medical shows. But the way Dr. Raju breaks this down, it feels less like gore and more like engineering or geometry.
That's the perfect mindset. I mean, endoscopy is largely about landmarks, lines, and measurements. If the lines don't match up, you have a problem. You have to think of the endoscopist as a surveyor. They aren't just looking for red spots. They're measuring distances from your front teeth all the way down to your stomach to see if the building blocks of your body have shifted.
So let's meet our patient. In the source material, Dr. Raju presents a case that's probably, familiar to a lot of people listening. We have a young woman, she's been dealing with heartburn for months. But it's not just the burn. She has regurgitation, specifically after those fatty meals we just talked about.
And occasional chest pain, too.
Right, which sounds like the classic triad for GERD, or gastroesophageal reflux disease. Now, normally a doctor might just prescribe meds based on symptoms. But for this deep dive, we're assuming we need to go in. We need to see the terrain.
So we insert the endoscope. We're traveling down the esophagus.
What are we looking for first? Because in my head, I just picture, smooth pink tissue. Is that accurate?
That's the goal, but you have to understand the layout to know what you're seeing. As you go down the esophagus, the lining is what's called squamous epithelium. And in a healthy state, yes, it should be a pale, clean pink. Think of it as the smooth pavement of a highway. It's uniform.
Okay. Smooth pavement, pale pink.
Got it. But eventually, that highway ends. You reach the stomach, and the stomach lining is completely different. It's columnar epithelium. Dr. Raju describes it so vividly, he calls it beefy red.
Beefy red. That is a very visceral description. I'm not going to forget that one.
It's unmistakable. And this creates a very sharp visual border. You have the pale pink of the esophagus meeting the deep beefy red of the stomach. That borderline is the single most important landmark in this entire procedure.
And it has a name, right? A pretty complicated one.
The squama-columnar junction.
I think I'm going to stick with what the doctors call it, the Z-line.
The Z-line works. It's jagged, kind of like a zigzag, which is where it gets the name. So you're looking for the Z-line. But at that exact same spot, you should see a second landmark. This one is structural. It's the top of the gastric folds.
Explain that. What are the folds? What do they look like?
Well, the stomach isn't a smooth balloon. The inside is lined with these ridges, or rugae. Imagine like a crumpled blanket or thick velvet curtains that are bunched up. Where those ridges, those folds end at the top of the stomach, that marks the gastroesophageal junction, or GE junction.
Okay, let me make sure I have this mental image right. In a perfect healthy body, The color change. The Z-line should be happening at the exact same geographic point as the top of the stomach folds, the GE junction.
Precisely. They should be superimposed on each other. If the color changes but the folds haven't started yet, or vice versa, something's wrong. But there's a third player in this alignment, the diaphragm.
The muscle that helps us breathe.
Right. And the esophagus has to pass through a hole in the diaphragm to get to the stomach. That hole is called the hiatus. Now, because the diaphragm is a muscle, it's dynamic. As the patient breathes in and out during the exam, the diaphragm squeezes the esophagus.
So you can actually see it hugging the tube.
You can see the indentation. It's called the diaphragmatic pinch.
So putting it all together then, in a normal exam, we're looking for a kind of cosmic alignment. The color change, the Z-line, the top of the stomach folds, the GE junction, and the breathing pinch, the hiatus. They should all be in the same spot.
Exactly. Dr. Raju notes that in a standard adult male, for instance, you'd expect to find this alignment about 40 centimeters from the incisors, from the front teeth.
40 centimeters down, that's our baseline.
That's the baseline. If you see that alignment, the anatomy is intact. The door to the stomach is where it should be, and the muscle guarding it is in the right place. But as we know, gravity, age, pressure, obesity, they can mess things up.
And this is where we get into hernias. I think most people hear hiatal hernia and just think pain. I didn't realize it was literally a math problem for the doctor.
It is a calculation of displacement. When the anatomy fails, it usually fails in terms of distance. Let's talk about the most common type Dr. Raju highlights, the sliding hiatal hernia.
The name itself suggests movement.
It does. Think about that alignment we just established. Now imagine the stomach starts to migrate. It pushes up through that hole in the diaphragm, the hiatus, and it slides into the chest cavity where it does not belong.
So the stomach is basically crashing the party upstairs.
Correct. And when that happens, the landmarks separate. The diaphragm stays where it is. I mean, it's a muscle wall. It doesn't move up. But the Z-line and the GE junction, that connection point, they move up with the stomach.
So they aren't lined up at the pinch anymore.
No. They've drifted north. And this is where the math comes in. Dr. Raju walks us through a specific example. Let's say you go down with the scope, you see the color change. The Z-line at 37 centimeters from the teeth.
Okay, 37. So that's where the stomach tissue starts.
Right. But then you have to go deeper to find the diaphragm pinch, the actual muscular gate. And you don't see that pinch until you hit 40 centimeters.
So the stomach connection is at 37, but the gatekeeper muscle is way down at 40.
Right, there's a gap. You take 30, you subtract 37, and you get 3. That means you have a 3-centimeter sliding hiatal hernia. The stomach has slid up by 3 centimeters.
It's wild to me that they're literally measuring the distance of the failure while they're inside the body. It's so precise.
It has to be, because the size of that pouch, the part of the stomach trapped in the chest, can dictate symptoms. It becomes a reservoir for acid. Instead of the acid staying in the stomach, it gets trapped in this little hernia pouch above the diaphragm, and it just easily splashes back up into the esophagus.
Hence the heartburn.
Hence the heartburn. The mechanical barrier is broken. But there is another type of hernia Dr. Raju discusses that is much sneakier, the paraesophageal hernia.
This one took me a minute to wrap my head around. How is it different from the sliding one?
So think of the sliding one as a vertical elevator. The whole junction moves up. In a paraesophageal hernia, the GE junction, that connection point, it stays put. It stays down below the diaphragm where it belongs.
So the main pipeline is anchored correctly. The elevator didn't move.
Yes. But the hiatus, that hole in the diaphragm, might be a little loose or wide. So the fundus, which is the top dome of the stomach, it squeezes through the hole next to the esophagus. It moves up parallel to it.
Oh, that sounds horrifying. It's like a second lane of traffic forming where there shouldn't be one.
Exactly. It bubbles up alongside the esophagus. And here is the so what for the listener. Because the junction is in the right place, the valve mechanism often still works. These patients might not even have heartburn.
They could be walking around with part of their stomach in their chest and have no idea.
Or just vague discomfort, maybe feeling full too fast. But Dr. Raju emphasizes that this is actually more dangerous than the painful kind. Because that piece of stomach is stuck in a tight space next to the esophagus, it can twist.
Like a balloon animal.
Essentially, it's called a volvulus, and it can cut off blood supply to that part of the stomach. That leads to strangulation and necrosis tissue death. It's a surgical emergency.
So the sliding hernia screams at you with heartburn, but the paraesophageal hernia might be a silent assassin.
That's a very dramatic, but a pretty accurate way to put it. It challenges the assumption that symptoms always equal severity. You can be in a lot of pain with a minor issue and in no pain with a life-threatening one.
Which brings us to another paradox that Dr. Raju mentions. The patient who feels like they are on fire, but the doctor sees nothing.
Ah, yes, the mystery of NERD.
NERD, non-erosive reflux disease.
This is a massive category of patients. Imagine you are the woman from our case study. You have the burning, the regurgitation. You are miserable. You go in for the scope, expecting them to find a total disaster zone. And the doctor looks at that pink squamous lining and says,
It looks perfect.
"It looks normal. No breaks, no ulcers."
I feel like that would be incredibly validating and incredibly frustrating at the same time. You know you're in pain, but the camera is basically calling you a liar.
It creates a lot of confusion. But Dr. Raju points out that normal to the naked eye doesn't mean healthy. This is why biopsies are standard. If you take a tiny sample of that healthy-looking tissue and look at it under a microscope, a pathologist can see the truth. They can see the cells reacting to the acid stress. The inflammation is there. It just hasn't destroyed the wall yet.
So NRD is basically the prequel to the damage. It's the invisible war before the walls actually fall down.
Exactly. It's the warning shot. But if that acid exposure continues, if the medication isn't worked out or the lifestyle doesn't change, we move from NANARD to actual structural damage. We move to erosive esophagitis.
And this is where we get to the grading system. This was the part of the video that felt most like a masterclass to me. The Los Angeles classification.
The LA classification. It's the global standard.
It's graded A through D. And unlike school, you really, really want to fail this test. You want a normal, not an A.
You definitely do not want an A, and you certainly don't want a D.
So let's break these down because the distinctions are really specific. Dr. Raju is very clear about the geometry here. Let's start with grade A. What are we looking at?
Visualize the esophagus again. Remember those longitudinal folds we talked about? The ridges running down the tube?
Yeah, like pleats in a curtain.
Perfect.
Yeah.
In grade A, the acid has caused a break in the lining and erosion, but it is small. The rule is it must be less than 5 millimeters in length. And crucially, it stays on its own pleat. It does not extend across the folds.
So it's a small, isolated cut. It's staying in its lane.
Correct. A minor breach in the hull. It's superficial. Now, if that erosion grows, we move to grade B.
What changes? Is it just deep?
It's about length. In grade B, the break is now more than 5 millimeters. It's a significant streak of red on the pink tissue. But, and this is the defining feature, it still does not bridge the gap between two folds.
So it's getting longer, maybe deeper, but it hasn't connected to its neighbor. It's still a solitary injury.
Exactly. It hasn't jumped the valley between the ridges.
Okay. So grade A is short and isolated. Grade B is long and isolated. Now we hit grade C, and this felt like the tipping point in the lecture. This is where things get messy.
Grade C is a significant escalation. Dr. Raju uses the term bridging. The damage is no longer staying in its lane. The erosions are spreading sideways, connecting the top of one fold to the top of another.
So you're seeing a web of damage now. It's not just stripes, it's a network.
Yes. The structural integrity is breaking down across the surface. However, there is still a limit for grade C. It involves less than 75% of the circumference of the esophagus.
So if the esophagus is a clock face, the damage covers a lot of it, but not the whole circle. There's still some healthy tissue connecting the top to the bottom.
Right. It hasn't fully encircled the lumen.
Which leaves us with grade D, the final boss.
Grade D is severe. Dr. Raju describes it simply as pretty bad, but medically it's critical. Here, the erosions affect more than 75% of the circumference.
It's basically a ring of fire.
It's a circumferential injury. The acid has eaten away the lining almost all the way around the tube.
Why is that specifically so dangerous? I mean, obviously it hurts, but what's the long-term risk of a grade D?
The risk is mechanical. Think about how skin heals when you have a massive burn that goes all the way around a limb. It scars, and scar tissue contracts. It shrinks. If you have a scar ring all the way around your esophagus, as it heals, it tightens like a noose. It creates a stricture.
So you physically can't swallow food. The pipe gets too narrow.
Exactly. You go from heartburn to dysphagia, inability to eat. That's why this grading isn't just academic. Dr. Raju notes that this is staging. It tells the doctor how aggressive they need to be. A grade A patient might just need to cut out late-night pizza and take a mild pill. A grade D patient, they need high-dose proton pump inhibitors immediately to heal that tissue before it scars shut.
It's amazing how much information is packed into those visuals. We've gone from looking for a simple pink tube to calculating hernia math and measuring mucosal breaks in millimeters.
It really changes your perspective on what a gastroenterologist is doing during those procedures. It's a survey mission in a hostile environment they are constantly measuring. Is the Z-line at 40 centimeters? Is the pinch at 40 centimeters? Is that erosion 4 millimeter or 6 millimeter? Does it cross the fold?
That's a great way to put it. And it brings me back to something we touched on earlier, the disconnect.
The disconnect between what you feel and what is real.
Yeah. I think that's the biggest takeaway for me from Dr. Raju's work. You can have the silent paraesophageal hernia that doesn't hurt but might strangle your stomach. You can have the agony of NERD with no visible damage. Or you can have grade C erosions that you've just been ignoring because you think it's just a little indigestion.
It totally exposes the danger of relying solely on symptoms. The I feel fine, so I am fine. Logic just doesn't hold up here. Anatomy tells the truth, even when your nerves are giving you mixed signals.
It really does. You have to look at the geometry. You have to check the pinch. You have to measure the slide.
Oh.
You have to trust the scope.
And you have to respect the Z-line.
Always respect the Z-line. That feels like a t-shirt waiting to happen.
I would buy it.
Well, on that note, we're going to wrap up our journey down the hatch. I hope this gave you a new appreciation for the plumbing that keeps us going and the detective work doctors like Dr. Raju do when it goes wrong.
It's a fascinating landscape. Just maybe don't visualize the beefy red part next time you're eating steak.
Fair warning. Huge thanks to the insights from Dr. G.S. Raju's series for guiding us through this. It's amazing to have access to that level of expertise. And thank you to you, our listener, for diving deep with us.
Until next time.
Keep your Z-lines aligned, everyone. We'll see you on the next deep dive.